This video is going to continue our talk on the pancreas. The pancreas. And we say your pancreas had two functions, the endocrine function and the exocrine. The endocrine was your hormonal function, your insulin, your glucagon, which we talked about in a previous video. That was your endocrine. Exocrine, we said, helps your digestive process. Digestive process. Just to recap on terminology, exocrine means you're secreting things into epithelium instead of the bloodstream, which is endocrine. So you're secreting things into the epithelium. What epithelium? It'd be your duodenal epithelium. So if we just draw out our pancreas and our duodenum. So there's your duodenum. And there's your pancreas sitting behind it. And it will secrete things in your duodenum to help the digestive process. What's one of the things it secretes? It secretes a lot of fluid, a lot of basic fluid. Why basic? Well, right above it is your stomach. And your stomach is very acidic, and it needs to be acidic to kind of break down food. So it's very acidic, and it'll release that broken down acidic juice, the chyme, into your duodenum. And we don't want that. We don't want something acidic into our intestines, otherwise it's going to scorch right through it. So our pancreas says there, I'll release some fluid, kind of neutralize it. I'll release some basic fluid, neutralize that acid. So it releases fluid. What's the main, I guess, base that we have in our body to neutralize acid? It'd be bicarb. You should know that in a resting low basal level, like I'm doing right now, I haven't eaten in a while. At a resting low level, you'll release some of that bicarb, and the cells of your pancreas will say, hey, bicarb's a very valuable commodity. I don't want to release it. So take some of it back and say, here, you can have something else instead. You can have another anion. You can have chloride instead. So in low levels, it'll exchange that bicarb for chloride, and that'll be your main thing in your fluid. However, if you've just eaten a meal, if I go out and I eat a big meal, you're gonna process that, release that acidic chyme into your duodenum, and your body will start releasing the fluid. At this point, it can't reclaim that bicarb. It needs that bicarb. It needs that really, really strong base. So at this point, at high demand, it'll release that bicarb. Some fancy ways they say it, it'll say like low flow contains a lot of chloride, or high flow contains a lot of bicarb. That's just a fancy way of saying it. You might say, what type of fluid is it? Is it hypertonic? Is it hypotonic? It's not hypertonic or hypotonic. I mean, if it's hypertonic and you release a ton of sodium and you turn hyponatremic and die, that wouldn't make sense. Your body's smarter than that. So it's isotonic fluid. Isotonic fluid. So you can release it and not worry about any changes in your electrolytes. Got it? Good. That's one of the ways your pancreas exocrine function helps you digest things. But probably the most important thing is that it releases a ton of enzymes. Your pancreas is the main player when it comes to releasing enzymes to break down food. And it breaks down everything. Your main food groups. Breaks down carbs, through things like amylase. Amylase is also found in your saliva. Your lingual glands will secrete amylase, but pancreas releases a ton of it. How about fat? It'll release lipase. Again, lipase is found mainly in pancreas, but there's also some minor amount in your lingual glands. However, you should know that lipase is more specific to your pancreas than amylase. It's found more in your pancreas than it is in your mouth. Last thing, protein. Gotta have that. Can we break down protein? Yes, we can. We can break down anything. That'd be your proteases. Not only do you have regular proteins to break down, not only do you have regular proteases to break down regular proteins, but you also have things like phospholipase to break down cells. That's pretty dang cool. You also have things like elastase to break down connective tissue. So if you eat a giant hunk of meat with a bunch of connective tissue, with a bunch of gunk in it, you can break down everything. Your pancreas can produce enzymes to break down dang near everything. And that's good in principle, but you gotta be very, very careful, don't you? I mean, you don't want it to go haywire and start eating your own body. So how does it manage to be very, very careful? How does it manage to only eat the things what it's supposed to eat? Well, your body is smart. So let's just take proteases, for example. Your body will release it as proenzymes. Proenzymes. These are enzymes that are not active. Sometimes we call them zymogens. Zymogens. Zymogen means something, an enzyme waiting to be activated. All right. So it'll release these proenzymes. They'll drop into the duodenum, and they're not active. They just kind of sit there. Okay. And they wait to be activated. What activates them? Well, your pancreas, being the great secretor it is, will secrete something called trypsinogen. Trypsinogen. And trypsinogen will come out and get released. And once it hits the duodenum, sometimes the jejunum, once it hits the wall of your duodenum and your jejunum, there'll be a enzyme right at the epithelium, the brush border, called enterokinase. Enterokinase. Sometimes called enteropeptidase, same thing. So this is found on the duodenal and the jejunal brush border. And this enzyme will turn trypsinogen to trypsin. It will activate it. And trypsin will go ahead and activate everything else. Trypsin will activate all these enzymes. And trypsin will also go back and activate any trypsinogen friend that wasn't already activated. So trypsin is the main activator. All right, main activator. That's a pretty clever way your body makes sure that all these enzymes are activated outside of your pancreas, in your duodenum where all your food is. All right, so release trypsinogen out into your duodenum, and only in your duodenum do you find that activator, enterokinase. All right, only in your duodenal brush border do you find that enterokinase. So it makes absolutely sure that nothing's activated until it hits your duodenum. Got it? Good. That's how it works in theory. What can go wrong? Well, if you smash your pancreas, then you can release these enzymes out into your body, and it can start eating your body, start eating your pancreas. That's no good. We can pick that up on labs. We can find things like amylase. We can find things like lipase in your blood because it's broken free, essentially. It's broken free, now it's floating in your blood. What is the most specific marker? Again, that'd be your lipase. And you see it in your blood. And once it gets outside, once those enzymes get outside, like I said, it'll start eating everything. And I'll start with your pancreas because that's the closest thing. That's where it came out of. And once it starts eating your pancreas, it can cause inflammation. We call that pancreatitis. Let's talk about pancreatitis. Pancreatitis, judging by the name, is inflammation of your pancreas, right? Pancreatitis. You can have acute pancreatitis. Acute pancreatitis. This is auto-digestion of your pancreas, auto-digestion. And once you auto-digest your pancreas, it'll start to liquefy. Because your pancreas has a lot of fat, you'll have a lot of fat necrosis. Fat necrosis. You're gonna have right upper quadrant pain. As you can imagine, it's gonna hurt. Right upper quadrant because that's where it's located. And it also, the pain goes straight to your back. Straight to back. Why does it do that? Because your Pancreas is retroperitoneal, so you get pain right to your back. Kind of like your kidneys. Your kidneys are retroperitoneal, and so if you have pyelonephritis, then one of the screening things you do on physical exams, you pound the patient's back and they'll jump out of the exam chair because it hurts so much. So right upper quadrant pain, straight to the back. Think of pancreatitis. You can have things like anorexia. Why do you have anorexia? Why don't you want to eat? Because anytime you eat and you get food, your pancreas will activate and try and release enzymes. If your pancreas is shot, then it'll release those enzymes more into your blood and just eat itself, auto-digest itself even that much more. So you don't want to eat because it just hurts. It hurts to eat. So you get anorexia. That inflammation can cause bleeding into the area, hemorrhage. Sometimes you can get hemorrhage and see it superficially. You'll get this kind of reddish spot on your flank. So right flank hemorrhage. Sometimes we call that gray Turner sign. Gray Turner. You can have hemorrhage bleeding into your periumbilical region. So you'll see these red marks right around your belly button. So right umbilicus. Like colon sign. I've been tested on this before. The way I remember is gray Turner is 2 words. You have 2 flanks. Colon, you don't need to know colon sign. Colon is 1 word. You only have 1 belly button. All right, so colon sign is redness in your belly button area, so umbilical bleeding. Gray Turner, the hemorrhage in your flank. Got it? Good. What causes pancreatitis in the first place? Well, I guess one of the most well-known memory aids for pancreatitis is Get Smashed. I'm not a big fan of these, but if it helps you remember it, all for it. Get Smashed is also in first aid. So Get Smashed stands for Gallstones. That's the G part. Ethanol or alcohol. Trauma. S stands for steroids. M for mumps. A stands for autoimmune. S for scorpion sting. H stands for hypercalcemia or hypertriglyceridemia, triglycerides. E stands for a procedure called endoscopic retrograde cholangiopancreography. Pancreography. This, judging by the name, endoscopic retrograde cholangiopancreography, you put a scope in endoscopically. You go until you hit the duodenum, and then you'll go back up your pancreas, retrograde up your pancreas, and you'll try and see how the duct is looking. All right, so you see whether the duct between your pancreas and your gallbladder is patent. That's ERCP. And then the last D stands for drugs. All these things can cause pancreatitis. How? How do they cause pancreatitis? That's much more important than actually memorizing these, because memorizing won't help you anywhere unless you know how. You can lump these into obstruction. So they're obstructing the pancreatic duct, causing a blockage. These enzymes will stay here, start to build up and eat itself. So obstruction, gallstones, you have a stone that blocks the duct. Cystic fibrosis, which is not part of the freaking memory aid, even though cystic fibrosis is very, very common. Your pancreas, the secretions get too thick and you get obstruction, pancreatitis. Hypertriglycerides. If you have too much triglycerides, your secretions again become too thick. Your fluid becomes too thick. There's so much triglycerides everywhere. Yeah, and it gets obstructed. And then this procedure, ERCP, because you're putting a scope in and you're trying to look through the duct, which you're hoping you'll find pan, but by putting a scope in, you can cause obstruction, you can cause pancreatitis. Direct damage, aka toxin, is going to be a second category, which we can lump these things into. Trauma, there's this one, right? Trauma is an obvious one. Trauma usually presents as a vehicular accident because your seatbelt goes right over here. And if you get in a car crash and your seatbelt smashes the living crap out of your pancreas, you can get pancreatitis. Usually seen in kids because their bones are a little bit softer, so it has a little bit more give. So it's like kids in car accident. You can also have it from a posterior duodenal ulcer. Your pancreas sits behind your duodenum, so you have an ulcer that can leak through and puncture your pancreas. Ethanol. Ethanol does both direct damage and obstruction. Ethanol is a toxin. Alcohol is a toxin. That's the direct damage toxin part. How about the obstruction part? Ethanol seems to reduce or constrict your sphincter, make it harder for you to secrete things. So, right, contract sphincter of your ducts. Steroids do the same thing as ethanol. So it can be a direct toxin, it also contracts the sphincter of your ducts. Mumps, this is silly. Mumps is not specific to pancreatitis. This is actually any virus can cause pancreatitis. The reason why they say mumps is because it fits into get smashed. Yeah, I guess putting a V here for viruses wouldn't make get smashed, so they just said mumps. And then autoimmune destruction, aka it's like diabetes, type 1 diabetes, scorpion sting, because the toxin is a direct toxin, and then drug toxicity. The only thing we're missing here is hypercalcemia. Why does hypercalcemia cause pancreatitis? Because calcium is very important for enzyme function. So if you have too much calcium, then it can go into your pancreas, rev up your enzymes, and cause it to auto-digest itself. Got it? Something important you should know, hypercalcemia causes pancreatitis. I just said that. However, once you get pancreatitis, you'll start to get hypocalcemic. Hypocalcemic. Why do you get hypocalcemic? In pancreatitis, you get fat necrosis. And anytime you have fat necrosis, calcium loves to bind to that. And once it binds to all that necrosis, then it'll take away calcium from the blood, and you get hypocalcemic. It's kind of like fat necrosis of the breast. If you have breast trauma and you get fat necrosis, then calcium will bind to a calcified. Yeah, you have this calcified lump. It scares the crap out of people, especially on mammography. So this is no different. Hypercalcemia will cause the pancreatitis, and once your pancreas is all inflamed, all that calcium will bind to it, and you'll get hypocalcemia. Once all that calcium leaves your bloodstream and binds to that inflammation. Okay, so you get hypocalcemia as a result. Very important you know that. All right, complications. What's the complications of acute pancreatitis? You can have DIC. Once those enzymes break free and release into your blood, you can get DIC. Anytime you have widespread inflammation all over your body, you get DIC. We usually think of DIC after septic shock. Don't you have widespread inflammation all over your body? It doesn't help that those enzymes also eat coag factors. So it just helps you bleed more in DIC. So it doesn't help that these enzymes eat the coag factors. You can have respiratory distress. Why do you have respiratory distress? Once these enzymes break free, they can go to your lungs, your alveoli. You won't be able to breathe. We said hypocalcemia already, due to it binding into your fat necrotic pancreas. You can have damage to an area and a cyst starts to form. However, when we think about cysts anatomically, cysts are always surrounded by epithelium. But in the pancreas, pancreatic cysts are instead surrounded by scar tissue, granulation tissue. So we can't call it a cyst, so we call it a pseudocyst. Complication of pancreatitis is Formation of pseudocysts. Cysts that are surrounded by granulation tissue. Also, we'll say you have damage to your pancreas. Then, also we'll say you have damage to your pancreas here. Let's say right here. And bacteria can go in, mainly E. coli, because E. coli is found in your gut. And we're in the right location. You can have an abscess. Abscess. E. coli. What are the giveaways that you have these two? They have right upper quadrant pain, radiating to the back. Their labs show lipase and amylase off the charts. Classic pancreatitis. So you hospitalize them, stabilize them. They're doing well. They're doing well. They seem all better. However, you redraw your labs, and amylase and lipase stay high. You're like, what the heck? I thought the pancreatitis resolved. It probably did. However, the complications of pancreatitis arose. So you might now have an abscess, and that's causing those amylase levels to stay up, or you might have a pseudocyst. All right. I've seen a lot of questions. They'll say a patient had pancreatitis, stabilized. However, their levels remain high, and then on CT of the body, they showed this cystic mass surrounded by granulation tissue. What could it be? Pseudocyst. Or they'll say a fluctuant mass that's very purulent. Abscess, okay? Just know those are complications and should be all right. That's acute pancreatitis. How about chronic pancreatitis? The main causes, especially from this list, is ethanol and CF. So ethanol plus CF. That's the main causes, unless you're really unlucky. I mean, you're not going to have 10 scorpion bites in a row. So ethanol and CF are the most common causes of chronic pancreatitis. And in chronic pancreatitis, that constant destruction of your pancreas will leave it atrophied and scarred and calcified. If you do an image of the pancreas, it'll look like this small, shriveled up thing, because it's basically destroyed itself. It's atrophied so much that it looks like a sliver of itself. So our atrophy plus calcified. Calcification? Yeah, calcification. Now, some complications you should know. Once you knock out your pancreas, you can't do what your pancreas does, help in your digestive system. So you'll have malabsorption, especially in fat-soluble vitamins, ADEC. Not enough that you know ADEC, you have to be able to recognize what it shows up clinically. What happens when you are missing these vitamins? What happens when you miss vitamin A? Things like night blindness, things like bit tot spots, that's that keratin spots on your eyes. What happens if you miss vitamin D? Osteomalacia. What happens if you miss vitamin E? That looks kind of like B12. Yeah, so neuropathies. What happens if you miss vitamin K? You have bleeding disorders. So petechiae, nosebleeds, bleeding to the joints, all that stuff. Understand? So I've seen a lot of questions like this long. They talk about someone that has, right upper quadrant pain, chronic right upper quadrant pain. Patient might be an alcoholic, and then is now complaining of bone pain, complaining of things like petechiae, stuff like that. They're talking about ADEC deficiency. So be aware. That's how they like to ask it. Okay. Also, the complication of chronic pancreatitis is an increased risk of cancer. That just makes sense. You have that chronic inflammation, that chronic cell turnover, increased risk of cancer. Now, before we talk about cancer, which is going to be our next topic, I just want to say, if you take labs in these patients, is amylase and lipase going to be high? Sometimes, sometimes not. You think that shriveled up pancreas is still making a ton of amylase, lipase? No. So just be aware that amylase and lipase at these levels may be low or normal. Amylase, lipase may be normal. All right, let's talk about cancer. Pancreatic cancer usually comes from the glands that line your duct. The glands that line your duct. So it's a glandular cancer. What do we call glandular cancers? Adenocarcinomas. So when we talk about pancreatic cancer, we're talking about pancreatic adenocarcinoma. Pancreatic adenocarcinoma. Very, very bad cancer, very poor prognosis, shows up very late. We pick it up very late because the signs are somewhat vague. You know, just a little bit of stomach pain, maybe more poo than usual, diarrhea because you're having malabsorption. So very vague signs. Sometimes when we pick it up, it's a little too late. So you need to know what clues in the history can tip you off to pancreatic cancer. That way you can pick it up a little bit sooner. There are three major clues. Three major clues. One of them is something called migratory thrombophlebitis. Migratory thrombophlebitis. Phlebitis is a blood clot that causes inflammation around the area. Cancers in general cause hypercoag state. All right, so if an old patient is doing well, suddenly they're hypercoagulable, you're suspicious of something going on. So any cancer can cause hypercoag state, but pancreatic cancer is just that much more important because it can leak out into your blood and cause vessel inflammation, cause thrombosis. So you get these blood clots that cause inflammation, and so you'll have these throbbing red marks on your arm, maybe one day, and then maybe the next day it'll jump to the other arm, and then maybe the next day it'll jump to your leg. That's why we call it migratory thrombophlebitis. All right, so they'll complain of something, a painful blood clot in one of their limbs, and then a week later jump to somewhere else. Dead giveaway. Pancreatic adenocarcinoma. Second clue. The most common cause or most common location of pancreatic cancer is going to be the head of the pancreas. Why? Didn't I say your pancreatic cancers came from the glands that line your ducts? Where are your ducts? The head of your pancreas. So the head is the most common location. And when you knock that off, you can have obstruction of this duct, and that can build up to your biliary tree. So just I'll say this is your gallbladder, okay? So it can build up into your gallbladder. And your gallbladder will enlarge. So it'll be palpable. Gallbladder. Usually not tender. So you'll feel it, feel this gallbladder, you'll push on it, patient doesn't do anything. As opposed to other things that inflame the gallbladder and you push on it, they'll jump off the bed. But this is palpable, non-tender gallbladder. Just from that buildup. And if you have that buildup and you can't drain, you'll have jaundice. So jaundice. Very, very, very classic. See many questions on this, not only in my step, but also in like just general med school exams about a patient that has jaundice, not really complaining of anything. You feel a palpable gallbladder that's non-tender, push on it, doesn't hurt. It seems like they're okay, they're doing fine, but they're not. They might have underlying pancreatic adenocarcinoma. All right, that's your second sign. Your third sign, we say your head is the most common location, but it can affect your body and it can affect your tail. In your body and tail, you have a lot of islets of Langerhans. Those are your endocrine cells. Those are the things that release insulin. And if you knock that off, then it's like causing diabetes. You'll have diabetes. So talk about an old patient, 90 years old, frail, eating the same diet, doing the same thing every day, and then a routine checkup to get diabetes. Something happened to your pancreas. And at that age, it could be pancreatic adenocarcinoma. That's your third giveaway. So be on the lookout for these, and they'll tip you off into possible pancreatic adenocarcinoma. What's the treatment? You take out the pancreas, you take out the gallbladder, you take out the duodenum, you take out everything. Yeah, everything in that area, because it's such a bad cancer. We call that Whipple's procedure. So you take out the duodenum, the pancreas, the gallbladder. How do we monitor it? We monitor it with a special blood test called cancer antigen 19-9. Cancer antigen 19. This isn't specific to pancreatic cancer, so it can't use it as a screen, but we usually get a baseline level once we diagnose it and then give the treatment, and hopefully we'll see it decrease. So we use it to monitor treatment and further management. Got it? That is pancreatic pathology. Hope that cleared things up. Thanks.